Hi, I'm New York State Attorney General Eric Schneiderman, and thank you for joining us here in our Facebook town hall to talk about the major crisis facing our country, the wave of opioids, prescription pills, and heroin, fentanyl, and other artificial opioids that really are sweeping the country and causing a public health crisis that really is unprecedented in American history. It's something that people realize is a serious public health emergency, but we wanted to talk about it in more detail, talk about some of what we've done in New York, and then take some questions so I can provide answers to some of the things that are on your mind. Please send us your comments as we go along, and don't hesitate if you have more specific or more personal problems to give us a call or go to our website at ag.ny.gov. So to give a perspective on this, it's sort of hard for people to grasp the severity of the problem, but the deaths due to opioid overdoses have been going up at a dramatic pace. In 2014, it was a little over 28,000 deaths nationally. 2015, 33,000. 2016 was over 50,000 people died from overdosing on opioids. Opioids now kill more people than both gunshot wounds and car crashes. It's really just a staggering figure. Drug overdoses have become the leading cause of death for Americans under the age of 50. And it's not uniformly distributed across our state or across the country. There's some areas with more severe problems than others. In Sullivan County, New York, for example, young people are being hit especially hard. Of the people who die in Sullivan County, New York, between the ages of 15 and 44, 41% of them die because of drug overdoses. So this is a problem that has spread to every part of the country. It's in cities, it's in rural areas, it's in small towns. And we've made a determination in our office to explore what the best practices were and to adopt what we call an all levers approach. We're not just going to look at one aspect of the problem, we're going to look at the problem as a whole and not rest until we can turn these horrendous numbers of death and the destruction of people's lives around. So since I became Attorney General, we've done a few things, some of them innovative, first time in the country. Others are just recalibrating the way we do our law enforcement activities, but I'm very proud of the work we've done. So let me say a little bit about it. We are cracking down on drug traffickers, but also helping New Yorkers get the treatment they need and ensuring that we can reduce the supply of opioids through really using smart technology and aggressive approaches to dealing with insurance companies and opioid manufacturers. The first thing that we did was to set up a program called the iStop program, which stands for the Internet System for Stopping Overprescribing. It is a program unlike anything that exists anywhere else in the country. We have a real-time database so that every doctor has to consult the database before writing a prescription, and every pharmacist has to consult the database before filling that prescription. This provides them with information, so if I walk into a doctor or a pharmacist, they can see if I have 2 prescriptions for oxycodone or 5 or 8, and it immediately helps them identify people who have an addiction problem. Since we initiated the iStop program and it went into effect a few years ago, according to the New York State Department of Health, doctor shopping, people going to multiple doctors for the same prescription, has dropped by 90%. This is just an incredible accomplishment, and we do believe that if this was a national model, it would have a tremendous impact because we can stop overprescribing in New York. It doesn't mean the drugs aren't flowing in across state borders. The other thing that we've done that has been more of just a recalibration of our approach is we have been going after insurance companies and health plans that create unnecessary barriers to treatment. This is a big problem all over the United States. We have been requiring health insurers to treat addiction the same way they would treat a broken leg. We have a mental health parity law in New York which really requires insurers to treat mental health and addiction problems the same as they do physical ailments, but a lot of them weren't doing that or were imposing barriers, requiring pre-clearance, having waiting periods, insisting on certain types of treatment before you could qualify for outpatient treatment and imposing just really unnecessary barriers. So we've been enforcing these laws very aggressively. It's important to understand that if you were in drug withdrawal, you're withdrawing and you really do want to get help, even a delay of hours can make a big difference. So we have reached settlements with a group of insurance companies. We're still negotiating with others, but we've hit plans that cover more than 3 million people so far. So that's been a very, very important part of our approach, to make sure that when treatment is available, there are not unnecessary barriers. The third thing that we've done is to redeploy our organized crime task force. And we did that through an initiative called SURGE, which stands for the Suburban and Upstate Response to the Growing Epidemic. We realized that the worst hit parts of our state, in many cases, were small cities, towns, and even rural areas where law enforcement tends to have fewer resources, they have less people, and they really needed our help. So through the SURGE initiative, we have busted a large number of gangs. We've, I think, made 260 or so drug arrests, charged more than 1,100 felonies, including, in addition to drug crimes, a conspiracy to commit murder in one case. And also in New York, we have a major trafficker statute, which is a felony carrying a very severe penalty. So we've developed a very good relationship with state and local law enforcement all around the state of New York. We also work with our federal counterparts in some of these cases. So we have been redeploying our resources where they're needed the most. As we were going through this process, we realized that law enforcement did not have naloxone available to them in many cases. Now, naloxone or Narcan is a drug that can be administered on the scene that will stop someone from dying from a drug overdose. It's really an amazing product, and we realized that our first responders didn't always have it. So we took drug forfeiture funds and created the Community Overdose Prevention Program, and have funded dozens of police departments all over the state of New York. So now police officers who arrive on the scene, if someone is overdosing, they can give them the naloxone shot very easily. It's administered nasally and save a life. And lives have been saved because of this program. So while we're trying to ensure that people have treatment, cut down on the supply of drugs, go after the bad guys who really are bringing these drugs into our communities, we also are trying to do harm reduction. We want to make sure that people have a chance to recover if they can, and the COP program has been very successful. Finally, we realize that there is a problem at the source. Prescription opioids start out as legal products. They're not manufactured in someone's garage. And so we've joined a multi-state investigation to go after the opioid manufacturers and look at the fact and subpoena records from both manufacturers and distributors of prescription opioids to look at whether their marketing practices are creating problems, to look at whether there's been any misinformation provided, because this is something that is a relatively new trend. I mean, 20 or 30 years ago, there were very seldom prescribed opioids for pain the way they do today, and we want to see what happened and if there's anything that needs to be corrected at that level. And I'm pleased to say that many of my counterparts from Attorney General's offices around the country have joined us, and we now have over 40 states involved in this comprehensive multi-state investigation. So those are some of the things that we've done in New York. That's why we call it an all-levers approach. We are prepared to look at every aspect of this problem, but we are not going to accept the notion that more than 50,000 people last year died from opioid overdoses. It is not something that is acceptable or sustainable. It's destroying families, it's destroying lives all over our state and all over our country, and we're committed to doing something about it. So we want to open things up now and take some questions. I'm very proud of the work we've done. And I do want to say, before we go further, if you have a specific problem or a personal problem you don't want to share with everyone on Facebook, call our healthcare hotline, which is 800-428-9071, 800-428-9071, or again, visit our website. We're always anxious to help people with their problems, and we also sometimes get good ideas from good folks out there. So if I can get where people have been sending in questions before we started this forum, and some people may be sending in questions now, so let me try and take a few of them as they come in. Thank you. This is from Ted in West Hempstead. I'm in my 60s and have seen all kinds of drug epidemics. This one is different. It seems to me to be sanctioned. How much responsibility does Big Pharma share in this crisis? Referring to the big pharmaceutical manufacturers. First of all, you're right. This is not like other drug epidemics we've seen. It reaches much further. The public stigma that used to be associated with drug use seems to be gone. There's really kids, middle-aged people, old people, rural, suburban, urban, are now getting hooked on opioids. And we know that a lot of it starts in the medicine cabinet, a lot of it starts with legal drugs, but people are moving rapidly to heroin, fentanyl, and other dangerous and illegal drugs. So it is a different kind of an epidemic. But the question of the responsibility of the pharmaceutical industry is something that is on many people's minds, and this is why we decided to band together with other states rather than going after them individually, company by company and state by state. We're going after the entire industry because it's a pretty consolidated industry. There are not that many pharmaceutical manufacturers who manufacture opioids, not that many distributors who distribute opioids. We're taking a look at the entire industry, subpoenaing records, demanding documents, demanding answers to our questions, because we do think there probably are some issues that need to be resolved at that level. But as I've indicated, we're starting at the very beginning, the source of the products, and going down to the level of making sure people who are overdosing don't die. So we're really taking a comprehensive top-to-bottom look at this problem. Thank you. That's a good question. Okay. This is from Susan from Whitney Point. Wrote in to say, I lost my 25-year-old daughter in 2016 to opioid overdose. One of the biggest problems we faced when she sought recovery was denials and stalling by her insurance carriers. Some of these barriers have been addressed, but even more needs to be done with insurance companies complying. What more can we do? Well, Susan, first of all, thank you for sharing your story. Very sorry for your loss, but it is tremendously meaningful that you're channeling your pain into an effort to help others. And I have to say that in all of my efforts, because there was opposition to us passing the iStop program, to us imposing limits on how much you can prescribe an initial prescription. We're in New York, we now have a 7-day rule that limits the initial prescription to 7 days worth of an addictive drug product. There was opposition there, and the families of those who had lost loved ones to opioid addiction were tremendously powerful force in lobbying to push through these sensible reforms, and you have been tremendous allies. Everyone who comes forward to tell their story adds their voice, and these are powerful voices, and it also makes it safer for other people to come forward. A lot of people have had fear of coming forward and admitting they had a problem in their family or they had a problem personally. This is a sickness. This is addiction is an illness. It's something that we should treat as a public health crisis. People shouldn't be ashamed to say they've got the flu. They shouldn't be ashamed to say they've got an addiction problem. But I thank you for contacting us. And yes, we have made it very much a focus over the last few years of looking at insurance companies and looking at barriers to treatment. Again, some of them are big barriers where they refuse to provide any coverage for certain types of addiction treatment. Some of them were small things like delays requiring pre-approval for certain types of addiction treatment, or preferring one form of treatment over another, even when a doctor would say, no, that's really not good for my patient to have to go through that treatment before they can get to the thing we think will work. We have been knocking down those barriers one by one, company by company, plan by plan, and have had a tremendous effect. Again, we've so far been involved in negotiating deals with companies that cover more than 3 million people here, and we're not stopping. So the message really is everyone has to step up to the plate on this one. Manufacturers and distributors are going to have to do their part. Insurance companies and insurance plans are going to have to do their part. We cannot put unnecessary barriers in the face of people who need treatment. And we're also going to have to be willing to make investments. This is something that state government does. It is clear that we save a huge amount of money if you can get people off drugs instead of having them run through the criminal justice system over and over and over again. Reducing, in New York, we're now reducing the prison population while the crime rate has been going down and our recidivism rate is going down. That's good public policy. but sometimes the funds that we save from law enforcement don't get invested in treatment. So we're taking on the insurance companies, but we're also strong advocates for making sure that good treatment programs do get funded for people who can't even afford insurance. Thank you very much, Susan. Okay. This is Elsie from Brooklyn, and it's a question about the stigma of those addicted to opioids. What are we doing to help law enforcement and public health officials approach people suffering from opioid addiction without stigma, and what can New Yorkers do? This is a really major issue, and I do think that the public's consciousness has shifted a lot in the last few years. A decade ago, conversations in law enforcement circles and conversations in public health circles were really very different about what to do with drug addicts, drug dealers. The conversations now are much more similar. I think more and more people are understanding that addiction is a disease, but it's very important for all New Yorkers to see that we all play a role in the way we talk about this. We have to be able to talk about it. The more people like Susan who come forward courageously and talk about a problem in the family, people who acknowledge that they've had problems, this is a way of humanizing this issue. And I will tell you this, as a law enforcement officer, it is 100% clear that we cannot prosecute our way out of a drug epidemic. We have to get people to come in for treatment. This is why the iStop program is a program not designed to punish people, but designed to prevent them from getting drugs in the first place, to enable doctors and pharmacists who are medical professionals who want to help people to offer them help. We have been removing the barriers from the insurance, and that really had to do with stigma also. The failure to fund mental health and addiction treatment and approve it as quickly as you would physical illness had also to do with an overlay of stigma. That's falling by the wayside, but it's really important for every New Yorker to understand that the way you talk about this makes a difference. You should encourage our friends to be honest about it and react to them with compassion when they tell you someone has an addiction problem. It is a disease, it is treatable, and we really do have very good empirical data on what kinds of treatments work for what kinds of patients. So there is a lot of hope that we can get out of this if we can shift from the outdated version of the war on drugs, which clearly didn't work, into a model where we reduce the stigma, we treat it as a public health problem, and we get this all levers approach going, not just in New York, but all over the country. Okay. We had two different people who both asked, what about people who need certain opioids to deal with chronic pain? Very important question. So in New York, we did not take an approach of trying to punish people who need opioids for chronic pain. In fact, that's the one thing that opioids are actually recommended for if you really have long-term chronic pain. They can be an appropriate treatment. There are pain management doctors and specialists who deal with this kind of thing. So iStop does not stop any doctor from prescribing opioids. It provides the doctor with the information to see if someone really needs them for long-term pain, or is doctor shopping, going to multiple doctors, and probably has an addiction problem or maybe dealing drugs. So our approach is not to cut off the supply. And pain management specialists, doctors who are specialists in treating pain and clinics that deal with pain, are really not the source of the problem here, because they manage their prescriptions. And our 7-day rule, which is very important because a lot of doctors were giving far too many pills for people who, say, had their wisdom teeth pulled or something like that. You don't need 60 pills for that. So the 7-day rule says initial prescriptions can only be for 7 days worth of a product. But if you have chronic pain, you can go work out a longer-term prescription program that is not as burdensome. So we're not doing anything to stop doctors from prescribing opioids where they're appropriate. We just know there are far too many opioids out there. There are far too many pills out there. There are some states in this country where there are more opioid prescriptions than there are people. That tells us something is wrong with the system. So we want to do this without interfering with legitimate pain treatment, and we think that our approach in New York is working very well in that respect. Thank you. Margot from Southampton. The opioid crisis intersects with the pharmaceutical waste problem. When citizens do have a clear and easy way, when they don't have a clear and easy way to dispose of unused pharmaceuticals, They hang around in medicine cabinets where family, friends, and even strangers have access to them. What can we do? That's really a critical element of this. And this really was behind our plans for both the iStop system and the 7-day rule to try and reduce the pipeline. But it is still a problem that when people have pills, a huge portion of heroin users acknowledge that they started their first opioid experience came out of a medicine cabinet. So this is something that is a serious problem. As a part of the iStop program, we created a requirement that there are year-round safe boxes where you can drop off prescription drugs, and you can go on the website of the New York State Department of Health and see where those are located. We also have National Take Back Day, which is coming soon. It's on October 28th, where we set up mobile sites all over the state and all over the country for people to drop those pills off. But it's very important to do it. Go on the Department of Health website. Let's clear out all our medicine cabinets. No point in having these pills lying around. They can't do any good, and they can do a lot of harm. One more. Okay, this is from someone who's tuning in on Facebook, Melanie. Suboxone is a lifesaver for many. What can we do to make it more accessible? So Suboxone is a drug that is used to get people off harder drugs, similar to the way methadone was used. Suboxone is a drug of choice for a lot of therapists, a lot of medical professionals who treat addiction. And it is one of the drugs that insurance companies were putting up unnecessary barriers to its use, and that's something that, and it's a part of our settlements with companies, we've forced them to remove those barriers. Major insurers like Cigna, Anthem, Blue Cross Blue Shield have put an end to the requirement for prior authorization for medication-assisted treatment, which includes Suboxone. So we are trying to strike down those barriers. It's something that has to be handled carefully because there are also people who divert Suboxone for improper use, so that's something that we also are monitoring. But this one really comes down to a bias against medication-assisted treatments in favor of non-medication-assisted treatments, which was frustrating, and there were a lot of doctors who could say, look, I know this patient, I can tell you that non-medication-assisted treatment is not going to work. There were barriers that prevented people from getting Suboxone. So we have been striking those down, and it's important for people to understand that different individuals respond to different types of treatment. Some people do very well in outpatient treatment, some people require inpatient, some require medicated assisted treatment, some don't. The point is to let the medical professionals make the decision. That is our goal here, and we want to make sure that they're empowered to do the right thing and to do the right thing without delay. Thank you. Okay, one more. This is from Greenlawn, Anne Arana. Is there a state or model program that is the most effective ways of treating the opioid crisis? There are very few states that have truly been successful in dealing with this crisis, which is why we're seeing the deaths continue to go up. In New York, we have made a lot of changes in the last few years that in some parts of the state we're actually seeing the numbers of prescriptions going down, and we think that we're on our way to the path out of this crisis. Medicaid in New York pays for inpatient treatment without requiring attempts at outpatient treatment. Again, that's a barrier that was hurting a lot of people. We have, insurers have to provide 14 days of substance abuse treatment without pre-authorization. We have lower prescription and overdose rates than many states, but it's still at a completely unacceptable level to those of us in New York. So while we have made some progress, there's more to be done. We do think that iStop is a national model. Having doctors and pharmacists in real time consulting a database makes a big difference. Again, the State Department of Health has studied this and shown that doctor shopping dropped by 90% since we instituted the iStop program. That is an incredible statistic. If that was true all over the country, the number of pills entering the system we believe would be severely reduced. Same thing for the 7-day rule. The Center for Disease Control has made some recommendations that some states are implementing, but I think that in New York we are a little bit ahead of the game with these programs and are, as I say, in some places seeing the number of prescriptions going down. So I'm proud of the work we've done, but we still have to deal with the manufacturers and the distributors, and that's a part of this multi-state investigation that is relatively new, but something we take very seriously. And we have to deal with the problem that this can't really be dealt with on a state-by-state basis. You need to have the national equivalent of an I-STOP program if we really want to stop doctor shopping and prevent these pills from flowing across state borders. So I thank you for tuning in. This is a discussion that I've wanted to have. I have with people all over the state. And please, if you have specific questions, call our 1-800 number, 800-428-9071. Go to our website. I'm Attorney General Eric Schneiderman. Thank you for joining us.